It literally affects every cell in the body. Every cell in the body has things called insulin receptors, which are these very specific doors, if you will, on the surface of every cell, from bone to brain, from lungs to liver, where insulin can come and knock on that door and basically tell the cell to do something. And one of its main actions, the one it's most famous for, is that it will lower blood glucose levels. When we eat something starchy or sugary, blood glucose levels will start to climb. If glucose stays too high for too long, that's actually dangerous, even lethal. And so insulin's a savior in that sense. It will come to certain cells on the body, especially muscle cells, knock on the door of the muscle cells, open doors for glucose to come rushing in out of the blood into the muscle, giving the muscle some energy, and other tissues, other cell types as well. So that's a general overview of what insulin itself is. And then insulin resistance is really this, it's two sides of a coin, and not a good one, unfortunately. So this is where someone has some cells of the body that for various reasons have stopped responding well to insulin. The muscle cells can become insulin resistant. And now when insulin comes and attempts to knock on the door to allow the glucose to come in, the muscle cell isn't responding. It's ignoring the knock, so to speak. And so the glucose levels will stay higher. That's one example of a cell that's becoming insulin resistant. But not all cells become insulin resistant. And that is where the other half, the other side of the coin, becomes relevant, because the other feature of insulin resistance, the first being, again, that some cells aren't responding, the other feature is that insulin levels themselves are elevated. So they're chronically up. So someone's living a life where every moment is spent with insulin being several times higher than it should have been, than it used to be when they were more insulin sensitive. And that becomes a problem because there are many cells in the body that are still responsive to insulin. And now insulin is overstimulating them. Insulin is working too well at those cells. And one interesting example is the theca cells of the ovaries. They are very busily converting testosterone into the estrogens, the prototypical female sex hormones. And that's the little known fact. All estrogens in men, all estrogens in men or women used to be testosterone. So in men or women, the part of the job of the testes and the ovaries is converting testosterone into estrogens. It's just that ovaries do it, of course, a lot more. And ovaries do it through the actions of an enzyme called aromatase. Now, these cells in the ovaries, called theca cells, they maintain their sensitivity to insulin. And so now insulin's too high, and it's overactive at the theca cells. One of the consequence here is that insulin actually inhibits that conversion from testosterone into the estrogens. And so now you have a woman with this elevated insulin, which is insulin resistance, and now her ovaries are not producing the big estrogen spikes that she needs for a normal, fertile menstrual cycle. And now the ovaries just start producing a lot of follicles and never one ovulating. And so the ovaries get really big and those little follicles become cysts. And now she has polycystic ovary syndrome, which is at its core a disease of too much insulin. Even in ladies that are lean, and you wouldn't think, oh, well, they're insulin resistant. They might not fit the profile in that they look like their normal weight. But even in normal weight women with PCOS, their fat cells have still become insulin resistant. And that is pushing this insulin resistance to or elevating the insulin. And that's then compromising the function of the ovaries. Insulin resistance is it's a combination of two variables. One, some cells aren't responding to insulin. And two, insulin itself is much higher than it should have been. And the two of those together are really acting together. That really is what explains why insulin resistance is so relevant. Most people would just think, if they know anything about insulin resistance, they would think, oh, it's just relevant to diabetes of some kind. But the truth is, as I certainly elaborate on in the book at book length, is that these two variables of insulin resistance really explain how insulin resistance is a fundamental cause of virtually every chronic disease. And if it's not causing the chronic disease, it's making it worse. What's relevant about that statistic that, almost 9 in 10 adults are metabolically unfit, we kind of take that one deeper level, and I don't think it's too much of an assumption to then say, well, that might mean 9 in 10 adults is insulin resistant. And unfortunately, because of how we view the disease, which I won't elaborate on yet because that is a different topic. But we don't diagnose the insulin resistance. We diagnose the manifestation of the insulin resistance. We tell the woman, you have PCOS. We tell the man, you have hypertension. You have fatty liver disease. Whatever it is, all of these disorders that the average clinician or the average clinical visit wouldn't imagine has a common core, but they do. And I certainly go into detail in the book, and that's one of the points of the book. It is to emphasize that there is a common cause of most diseases, and that's a good thing because then we can treat one thing. We don't have to give them a drug that's treating the symptom, which is really all a drug can ever do. A drug can never cure a disease. It can only ever treat symptoms. And so I think there's something kind of liberating about this perspective that there is, and I'm not saying insulin resistance is the sole cause of chronic disease, not at all. I'm not so bold or naive to say that, but it is definitely a big part. And that should be good news because that is something, that is one single point of attack that we can address. And so then rather than this, so you imagine a typical overweight Canadian or American, and he opens up his medicine cabinet. He has to take his anti-diabetic drug, his anti-hypertensive drug to control his blood pressure, and maybe one more for his erectile dysfunction. And then imagine how liberating it is to realize, wait a minute, I can get rid of all those medications, which are simply all addressing symptoms of one common problem, insulin resistance. And so to your question, what about the solution? In fact, the solution for reversing insulin resistance is the same for preventing it. So I can kind of address both of those issues in one. And I believe firmly the most effective, rapid way of reversing insulin resistance is to lower the insulin, change a person's eating habits to bring the insulin down. And now all of a sudden the body becomes more insulin sensitive. And the lower insulin itself, those two events together, we have removed the insulin resistance, and all those surrogate or derivative problems begin to resolve. The person's blood, in fact, blood pressure is so intimately a result of insulin resistance that within days of someone changing their diet to lower their insulin, they have to get off their antihypertensive medications because they start fainting. Their blood pressure has gone so low so quickly. And the same thing within weeks of anti-diabetic drugs, like Dr. Jason Fung has shown, within just a few weeks of a person changing their diet, they have to stop taking their insulin injections for a type 2 diabetic because they don't need it anymore. Their glucose is going too low. So it's a phenomenal. It's a liberating. I use that word too often. But it is. It should be looked at as very good news, where someone can say, I can save money. I can save on the side effects of these medications. I don't like how they make me feel. I don't like taking them. Well, the good news is the gospel of this is that you can change. You can change it. The food you eat is either the culprit or the cure. And again, if you look at it as a cure, you look at it through the lens of, what will this keep my insulin low? And that is why the default then, if someone listening to this would say, okay, great, Ben, well, how do I do that? The solution is simple. It really is as simple as control your carbohydrates, avoid those foods that are spiking your insulin, which are refined starches, and sugars, which are abundant. They're ubiquitous. They're everywhere nowadays, whether it's Serbia or Singapore or Canada or anywhere else, they're everywhere. And the sooner we start controlling carbohydrates, focusing on the least starchy and the least sugary foods, then the sooner insulin can come down. And now the body starts to almost seemingly miraculously heal itself. But it has to start with controlling carbohydrates. And then, of course, the person would think, well, what do I eat then? If I can't eat bread and bagels and cereal, then focus on protein and fat. Those are not only essential, there are such things as essential fats and essential amino acids, while there, as you know better than most, there's no such thing as an essential carbohydrate. But I'm not saying don't eat any carbs. I'm not saying that, but focus on the foods that we actually need, proteins and fats, and coincidentally have little to no effect on insulin. So someone can eat a big juicy steak and their insulin will barely have a hiccup. I will actually go on kind of a water carnivore week to just check those addictions, to put them in their place. And when I'm measuring my glucose on my continuous glucose monitor, it is a flat line literally the whole time. The first would be stress. So the primary or the prototypical stress hormones like cortisol and epinephrine, those are directly antagonistic to insulin, and cortisol in particular. So someone who's had to take like a common course of treatment, for example, for rheumatoid arthritis or any type of arthritis, might be a cortisol analog, like a prednisone or a dexamethasone. And those will cause the body to become insulin resistant very quickly. And then the insulin is going up and now the fat cells are holding on to energy more. And you've had Jason Fung on previously. So this is something he's very much eloquent and elaborated on well in the past. So that's why the person taking these anti-inflammatory steroids, they are cortisol-like molecules. They cause the body to become insulin resistant, and then all the consequences that come from that. Inflammation is a distinct cause of insulin resistance on its own. And so, in fact, let's mention rheumatoid arthritis again. That's an autoimmune disease. And like most autoimmune diseases, it will have active and passive phases. You know, their joints are really bad for a couple of days. And they're all right now. They're really bad. And that's very likely because of an environmental exposure, as you would know better than most. When many autoimmunities are triggered because of something in the environment, something they're ingesting in some way, shape, or form. So with rheumatoid arthritis, it's interesting to note that when someone is in an active phase of the disease and they have higher inflammation, higher joint pain, you can detect an increase in insulin resistance that ebbs and flows as the disease is more or less active.
So you can measure that?
You can, yeah.
Wow.
There's a study that's been done in humans to show that. Yeah. So that's the second one. Inflammation is a cause of insulin resistance. And then lastly, the one that I believe is the most relevant in a long-term situation is too much insulin itself. Now, the astute listener would remember from just a few minutes ago, well, wait, Ben, you just got done saying that elevated insulin is a feature of insulin resistance. It is. It's also a cause. And we see this in laboratory settings, including from my own lab, but in humans even, if someone has chronically elevated insulin, the body stops responding to the insulin. So too much insulin is a cause of insulin resistance. Now, some people balk at that explanation, but it really is fundamental of just biology. Too much of a stimulus will result in a resistance to that stimulus, whether it is a hormone, whether it is an antibiotic, whether it is a drug, whether taken for medicinal purposes or abused. The person will need more and more of that drug to get the same response that they used to get from a smaller amount. So insulin is no exception. When a stimulus is incessant at a cell, the cell will start to turn down its sensitivity to that signal. And so too much insulin is one of the primary causes of insulin resistance. And then the last one that I need to mention is more of a secondary, because I can't induce insulin resistance, for example, on cells by directly treating the cells with this molecule. But that would be the omega-6 polyunsaturated fatty acid, linoleic acid. So the fat that is abundant in these artificial seed oils, like soybean oil, or in Canada, in Alberta, you always see these canola fields. Canola oil is the same. It's these really, I guess, industrial seed oils that 100 years ago had no place in our diet. And they are more of an indirect effect because they make the fat cells become insulin resistant. And when the fat cells become insulin resistant, they're typically the first domino to fall. And I won't elaborate more beyond that, lest I get off on a whole other topic. But insulin resistance is sort of this process of one tissue falling, like it would be the first domino. And I believe it's the fat cells that become insulin resistant first. And in so doing, they then start bumping into other tissues like muscle, liver, brain, etc. I am a huge advocate of ruminant animal consumption, of ruminant animal products in the human diet. There's something just beautiful. It's elegant. It's intelligent that this is an animal that can eat a food that we cannot. We cannot eat those grasses at all. So this whole kind of vegan myth that we can eat like an ape does, we can eat like a cow does. No, we cannot. We cannot thrive on that kind of diet. So to be able to have an animal that can take a plant like grass, which is directly getting energy from the sun, and then captures that energy, harnesses it, and because of its miraculous stomachs, can form all the foods it needs. And then we, as apex predators, can then come in and eat that animal that can't eat any of the other grains and plants that we might want to enjoy. They're not supposed to eat those. They're supposed to eat the plants that we cannot eat. And thank heavens for that. I think there's something beautiful about it. Really, my central thesis in the book, in a way, is we need to put insulin on the radar, including measuring it clinically. Measure your insulin. As someone who's hearing this and is about to have a clinical visit, do what you can, beg, plead, whatever, to get your insulin measured. And if it's below 6 microunits per mil or around 30, 35 picomolar, then that's a good sign, then you're doing great. A second measurement is actually looking at your blood lipids. And this one's a little more accessible because we always were so obsessed with blood lipids, which is fine. I don't think that's unwarranted. But that means someone will always have their triglyceride number and their HDL number, the HDL cholesterol. And so this sort of poor man's method, a surrogate of getting a feel for what your insulin sensitivity status is, take your triglyceride number and divide it by your HDL cholesterol number. And if that ratio, triglycerides to HDL cholesterol, is 1.5 or less, that's a good sign. That's a person who's insulin sensitive in general. So to sum it up, get your insulin measured. And if you can't get your insulin measured due to insurance constraints or medical system constraints, then focus on your triglyceride to HDL ratio. You will always get that measured no matter where you are. And if it's less than 1.5, then that's a green light. You're doing all right. So metabolic syndrome, as I mentioned, is a constellation of 5 disorders. And over the years, there have been a few kind of rolling definitions of it, but the consensus has settled on these 5. Let's see if I can rattle them off. 1 is elevated blood pressure, so hypertension. 2nd, elevated glucose levels. 3rd, elevated waist circumference, so central obesity or adiposity. And then the 4th and 5th are kind of related, which is just sort of bad blood lipids. And specifically, they break them up into 2, elevated triglycerides and low HDL. When we look at it as insulin resistance syndrome, now we understand the origins of these problems. If someone is insulin resistant, they will have elevated triglycerides. They will have lower HDL. If they're insulin resistant, they will have higher glucose and higher blood pressure. And the central obesity can both be cause and consequence of the insulin resistance itself. But altogether, those constellation of disorders are much more derivative or more accurately described as consequences of insulin resistance rather than just a vague, you're not metabolically fit. A physician gets paid to see patients. That's the job of the physician. I'm a scientist. I get paid to ask questions. Now, I don't get paid as well. It's not as lucrative to be curious as seeing patients, but that does mean I can sit back and say, how does hypertension have a metabolic origin? Why is it part of the metabolic syndrome? Oh, it's because of the insulin doing this and doing that throughout the body, at blood vessels, at the adrenal glands. It's affecting the way the body's behaving with regards to its blood volume and blood pressure. And so I know that. And so my most favorite audience is actually when I get to go give talks at clinics about these kinds of things. I love speaking to nurses and doctors and hospital administrators with no ego. It is not my ego that drives that interest. It's because there's a genuine delight on my part to think this is the way it ought to be. There ought to be the scientists in the lab, the boring kind of their version of white coats, finding answers to questions. They convey those answers to the actual practitioners who are on the front lines doing all kinds of, wonderful things, but they don't get paid to sit back and kick up their feet in their desk, look out their window and ask themselves these questions. I certainly feel frustration in my own right with how people look at type 2 diabetes and where the average clinician will look at type 2 diabetes as completely a glucose problem. And they'll say, your glucose is too high, and they won't have any awareness of insulin. Insulin's not even on their radar. But the tragedy in this situation is if someone's developing insulin resistance, as the audience now knows, their insulin is high, but the insulin is enough. There's enough function of the insulin that it's able to keep the glucose at normal. And so the patients coming in, they get diagnosed with PCOS or hypertension or fatty liver disease, and they're not even looking at the insulin. If they did, they'd see that it's much higher. It's only years later that now the body's become so resistant to its insulin that now the glucose starts to climb. Wow. And then they detect the problem and they say, well, you have type 2 diabetes now. And the tragedy doesn't end there, but that's the first tragedy, is that by looking at type 2 diabetes as a glucose disease, we detect it too late, potentially decades later. If we'd looked at it as an insulin disease, we would detect it much, much sooner. And second, if we looked at it as an insulin disease, we would treat it better, because the tragedy in type 2 diabetes is the type 2 diabetic has very high insulin and very high glucose. But because we look at it as a glucose disease, the physician will say, well, let's just give you more insulin. Let's put you on insulin therapy or give you drugs that will push up your insulin. And they might not even know what the insulin is, but it works to lower the glucose. And so if this were just a glucose disease, we would say, well, we've solved the problem. But the reality is when we give a type 2 diabetic insulin and they already have high insulin, which they always do in type 2 diabetes, then we make them fatter and sicker and we kill them faster. Their risk of dying from heart disease triples. Their risk of dying from cancer doubles. Their risk of getting Alzheimer's doubles. We are killing them by giving them insulin. But kind of to your point, the cynical view that I somewhat share, conventional medicine would just say, you can continue to eat high carbohydrate diets. In fact, eat every 2 hours. Just make sure you cover it with insulin. That is an asinine perspective. It is killing patients. When we put a type 2 diabetic on insulin and tell them to eat what they want and just cover it with insulin, it's a wonderful way to sell more insulin, but it's a terrible way to help a patient get better. If we look at it as an insulin-centric or through an insulin-centric paradigm, then we say, all right, you have chronically high insulin. How can we lower your insulin? You know what? Eat less carbs. You don't have to go zero carb to do this. Just eat less carbs. We published a paper, a clinical case study with a clinic here in my area, and we took 11 middle-aged women with type 2 diabetes, full-on type 2 diabetes, and we put them on they had an option when they were in that clinical visit, having just been diagnosed with type 2 diabetes. The option was you leave with a drug prescription, the consequence of which will be that you have to continue to take that drug forever, and you'll likely have higher and higher doses of it, or you have a nutritional prescription, if you will, and it's going to be the simple rules that I outlined earlier. Control carbs, focus on protein and fat. And within 90 days, these 11 women, but were part of the case study, they elected to follow the low-carb, even ketogenic diet. And within 90 days, they had nary a whiff of diabetes. Their glucose was totally normal. They had lost 20 pounds. Their blood pressure had come down. By any definition of the disease, we had cured it, which is a term you're not supposed to use with type 2 diabetes. You're not supposed to say you cure it, because if you just use drugs to solve the problem, well, you never will. You will never cure it. The great myth of weight gain or weight loss is you have some 20-year-old, dude who's bragging about, I of course, I have them all over here because I'm a university professor. He's bragging about how he can eat whatever he wants because he has such a high metabolic rate. Or you have people like who are older, out of school. Oh, I gained 10 pounds or I gained 20 or 30 pounds. Once I got married or once I had a baby, my metabolism just really slowed down. All of that is totally false. There's nothing to support that perspective at all. In fact, with pregnancy in mind, a part of the great it blows that myth apart quite well, because the moment a woman becomes pregnant, over the next 9 months, her metabolic rate is going to get faster and faster and faster, because metabolic rate is just the sum of all the chemical reactions happening in the body, building things up and breaking them down. Anabolic and catabolic, that is metabolic or metabolism or metabolic rate. And so metabolic rate does not predict weight gain. In fact, there was a study anyone could look up called the Baltimore Longitudinal Study, and they basically followed a bunch of guys, about 1,000 people, for 10 years. And they measured metabolic rate at year 0, and at year 10 follow-up, what their baseline metabolic rate had been at year 0 in no way predicted who gained or lost weight the most or the least to any degree. However, in that same study, there is an ounce of explanation for what might have predicted their weight gain or what might have been responsible for it. And they looked at something called the respiratory exchange ratio. The RER is a measurement of what fuel we're burning. Now, very briefly, human metabolism is like a hybrid, where at any moment, the overwhelming majority of all the energy our cells are getting is coming from a mix of glucose or fat. So blood sugar or fat. That's the main fuel. And it's a mix at all the time. We're never burning just one or just the other. All the cells in the body are using these two fuels and shifting between them as needed, maybe because they've eaten or because they've fasted. But basically, the RER will tell you, are you more sugar burning or are you more fat burning? What they found was that the people that were more sugar burning, that glucose was responsible for the majority of the fuel their body was using, they were the ones who gained the most weight. In contrast, the people that were more fat burning, they gained the least amount of weight. They were the more likely to stay lean. So someone hearing this would say, okay, well, I don't want to be a sugar burner then, because then my chances of gaining weight over the next years is going to be higher. Yes, that study would suggest that's true. then the follow-up would be, well, how do I then become a fat burner? You burn what you eat. And unfortunately, because we are such a carb-obsessed culture, the world is obsessed with carbohydrates. No one is sitting around on a Saturday night about to indulge in some shows, some TV shows or movies, and they're thinking, oh, I sure want a plate of scrambled eggs. No one.
Okay, just to interrupt, I watched The Jungle Book with Scarlett last night.
Yeah.
And we had chicken wings. Just chicken wings and salt, so super crispy, but in our popcorn bowl. So there are some people who are doing that, but it's fairly rare.
Because we are craving something that is salty and crunchy or sweet and gooey, and that is almost always going to be carbohydrate. Now, you actually found a clever way around it by just crisping the chicken. Yeah, so that worked. And unfortunately, because we're obsessed with carbohydrates and we eat every 2 hours, we are constantly in sugar burning mode. And it's only once we lower the carbs and or fast do we shift over to fat burning mode, where we can shift between these fuels. And once again, insulin rears its relevant head even in this process, because insulin, this hormone, is what dictates which fuel we're using. If insulin is elevated, we are obligatorily burning glucose. We're sugar burning. If insulin is low, we shift and we start fat burning. In fact, if insulin is low for an extended period of time, like 16 to 20 hours, we start burning so much fat that we actually are burning more fat than we need, so to speak. And some of that fat gets metabolized into ketones. It's called ketogenic, really because it's burning fat like gangbusters. It's just tearing through the fat in the body. It's burning it at such a high rate, we start making ketones from it. If you're fat burning, it's easier to control your weight because those fat cells are not filled with glucose. They're filled with fat. And it's only once we start burning fat can we actually start to control our body fat. If we're stuck burning sugar all the time, those fat cells are never touched in a general way, in a generic sense. And thus they just keep pulling in energy, never actually using it because we aren't burning fat. Why might someone be gaining weight more easily than another? Part of it could be just the composition of the foods they're eating and their inherent differences in insulin sensitivity. Insulin resistance is genetic, where some people will just be more insulin resistant than other people. So those people that are more insulin resistant naturally, they will have to fight harder. Their insulin is going to want to be higher all the time. And so it'll be a harder fight for them to keep it low, but they can do it. And once again, the truth of the situation is it's not their metabolic rate. It's really the sentiment of what fuel are you burning? If insulin is high, you're burning sugar, you're not burning fat, and the insulin is going to stimulate the fat cells to grow and store energy rather than break things down.